Good afternoon, everyone, and I thank Dr. Mehul Shah for involving me in this prestigious IC. So, the 6-month incidence of developing post-traumatic glaucoma in closed globe injuries is almost about 3.4%. And how it is different from regular glaucomas, one is that it's unpredictable, the pressures are very high, not amenable to medical management many times, and the patients are much younger. So this is the difference between traumatic glaucomas and regular glaucomas. So the IOP rise in any case of traumatic glaucoma, we can say it can be acute, which is short-lived, acute unrelenting. Pressures don't go beyond 50 no matter what you do. Chronic, the acute phase goes into a chronic phase, but maybe at a lower IOP, and a late onset glaucoma. So you can divide it into these 4 categories. And the acute rise could be without, I have divided into 2, with hyphema and without hyphema. So it could be, the causes could be just the trauma, that is disruption of the trabecular meshwork. Angle recession is an indication of disruption, and immediately it will not cause high IOP. But because it's been disrupted, the TM, the IOP will rise. Inflammatory debris, if there is a lot of inflammation, it will block the TM. Iris pigment, yes. Lens particles, if the lens has ruptured, then the lens particles, vitreous normally 360 degrees is not going to block your trabecular meshwork, but it's an indication of how badly the injury has damaged the eye structures. So lens subluxation, it can block the angle because of various reasons. And trace hyphema. Sometimes you may find there may be a gap of 3-4 days before the patient presents to you, and you may find that there's no hyphema, but you put a gonioscope if the cornea allows you, and you'll realize that there is trace hyphema. And why I say it's important? Because it changes the approach to some extent, and even though you say it's a non-penetrating injury, you will be sometimes surprised to see a foreign body. So do a gonioscope no matter how quiet the eye is. It will give you additional information. And then you have acute IOP rise. So in the acute phase with hyphema. So with hyphema, you may have all the other causes which are listed in the previous slide, but the RBCs, the bulk of the IOP rise is because of the RBCs blocking the trabecular meshwork. It is not very common in our country, but if a patient has sickle cell disease, then you cannot give carbonic anhydrase inhibitors, because they will, the RBCs will sickle and they will further block the trabecular meshwork. So here, what is the late onset glaucoma? So late, how late? It ranges from months to years. And let me spend a little more time on angle recession glaucoma. It's a very different kind of glaucoma. What is angle recession? I will not go into the mechanics of why it occurs, but it's basically because of the contusive, the force, there is a split in the longitudinal and the circular fibers of the ciliary body, and that is an indication of the damage, the amount of trauma the trabecular meshwork suffers, and that is angle recession. It is seen in after say few years, it is just seen as a wild, as a white broad band, and you will not realize unless you see carefully. If you see it after a few years, you have to be very, very careful to look for it. And typically the patient will come after unilateral, as a unilateral glaucoma, and you will try to find the cause, but that's when gonioscopy really helps, and a detailed history. The patient would have forgotten that I had an injury. And angle recession can occur years also. The second is a closure of, these are glaucomas which actually occur late after the trauma, closure of cyclodialysis cleft, that the pressure may be high, but because there is a cyclodialysis cleft, it acts as a treatment. It masks the elevated IOP. And this cyclodialysis cleft can close later at any time, and that is the time when the IOP will go high, and you will again label it as a late onset glaucoma. Again, it will be unilateral. History is of paramount importance. And of course, the surgeon or the ophthalmologist who had seen the patient first, if the patient had even gone to an eye doctor, should have done a gonioscopy. The other is, now these are over a few months, that phacomorphic, phacoanaphylactic lens subluxation which worsens can be a late onset glaucoma, but not years later, maybe a few months later. Retained IOFB, if you have not done a gonioscopy, even if you are saying that it is a closed globe injury, retained IOFBs have been seen, you know. and epithelial downgrowth. So that's not a very common cause, but this is just to complete the list. So what you have to know from all this is, the way you say, if you have had an injury, the retina examination has to be done once a year, year and a half, forever. Counseling for glaucoma is also for a long-term follow-up. The patients have to be counseled that no matter you're fine now, once you become better, every 1.5 years, you should come and get your eye examined. One more thing which I want to tell you about angle recession is that when it is late onset, many times don't forget to look at the other eye, because it is said that it's a person who is prone to primary open angle glaucoma will develop glaucoma if he has angle recession, and the other eye will also develop a POAG without any history of injury. So look at the other eye in case of angle recession when it is late onset. So treatment principles in general in the acute phases, that of course you assess the vision and the other anterior segment and posterior segment parameters, assess the IOP. Now the cause of elevated IOP, whatever it is, steroids, topical and oral form the mainstay of treatment, along with atropine and acetazolamide and IV mannitol. If there is corneal edema, assess the, put a gonioscope, assess the angle, and this can evaluation and fields later on when possible. Medical management, I have seen people are not very keen on using prostaglandins, but prostaglandins should be used. There is no contraindication. The only thing which you should not use is pilocarpine, and this is one exception. We always say step by step increase in the first use 1 drop, then add the other. No. In traumatic glaucoma, when the pressures are very high, you start everything at once except pilocarpine, including tablet Dimox. One more thing, of the optic nerve is healthy. So for a short time, if you are able to get the pressure down in the acute phase between 20 and 30, it's fine, because it can tolerate these IOPs for quite some time. And why I say with hyphema, without hyphema, even if you feel, most of the times conservative management of hyphema, waiting and using all the other things which I told earlier helps. But however, sometimes it's intractable, and even though you feel that the AC, there is not so much of hyphema, it still helps to do an AC wash. Debulking the anterior chamber really helps a lot in decreasing the load on the trabecular meshwork. So even if you find trace hyphema, please do it. Now here this is one person, after about 7 days the pressure just wouldn't come under control, and I had taken him up for AC wash. I had put pilocarpine, but because he was an atropine, the pilocarpine did not constrict the pupil completely. You have to be very gentle. You can't pull on the clots, because you may have a rebleed. Again, you keep on doing this for some time, because the liquid blood is hidden, so I don't know whether it is, and then you have to have an air tamponade. So sometimes the moment you take your cannula out, it keeps on bleeding again. So at one from how the retinal surgeons do a air fluid exchange. So you can just irrigate on one side and push air through the other side, so there is no fresh bleed. I know it is, I have exceeded my time. Can I have about half a minute, please? Yeah. So success rates of TRAB recently 88%, and success rate of tube in case medical management does not work, both work well. In my experience, if it is a younger patient and if it's a more severe injury, TRAB fails very fast. I would go in for a primary tube. But if it's an elderly patient, I would certainly do a trabeculectomy. And we don't have time for this. So the take-home message is that lifelong monitoring is necessary. And yes, if you find that the pressures are just not coming down, then you should intervene early, because the fields have gone from normal to tubular in 1 to 2 months. AC wash, if you find even little hyphema, do attempt it before you go in for TRAB or tube. Prostaglandins can be used very safely. Avoid pilocarpine. SLT has a limited role to play. TRABs and tubes work very well. TRABs, if the patient is older, yes, TRABs work very well. If the patient is younger, say between 10 to 20 or even younger, then tubes work very well. So thank you once again for a very patient listening, and thank you, Dr. Mehul, once again.
Thank you, Dr. Preeti, for that extensive and very nice coverage of the subject of post-traumatic glaucoma. We have the panelists for this particular talk, Dr. Lipi Chakravarti, Dr. Amit Pandey, and Dr. Rinal Pandit. We'll request them to use the mic and discuss the aspects that they would like stressed.
Brilliant presentation as always, ma'am, and ma'am has covered almost everything. Just 2 points I would like to restate. Yeah, counseling of the patient when the patient comes to you. The departments also should know that if the patient has a blunt force trauma, they should refer it to a glaucoma specialist, even if the pressures at the initial stages are not very high. Because we need to counsel the patient, we need to see the angles, if angle recession is there, we need to counsel the patient that you have to have a follow-up, probably initially every 6 months and then later on at least every year, because glaucoma can happen at any stage, even many years down the line.
So on this subject, Dr. Preeti, you mentioned about possible early drainage of the hyphema in some cases. Does it have a greater tendency for rebleeds in the post-drainage phase? Because that was one of the reasons why we were told to be more conservative. In some of the cases.
If the pressure does not come under control, the AC wash which I showed, no matter what I did, the pressure did not come down below 40. After about 6 to 7 days of conservative management also. So if you, with medical management, you are able to get the pressures between 20 and 30, then I would say wait and watch. But if it's not, then because of the same, the moment you remove the clot, there is a fresh bleed, if it's done early. So that's why only in intractable cases is what I say that you should go in for AC wash.
I have 2 points to make. One is measurement of intraocular pressure. So many of the comprehensive ophthalmologists, they ask me that how to measure pressure in case of a blunt trauma or even penetrating injury, whatever. So even digitally it can be done, we can have an idea. And if Boltzmann is not possible, then as rightly told, refer to a glaucoma specialist, tonopen, or there are other methods, DCT, dynamic contour, it's not available freely. So this can be used. And second, gonioscopy. It's not necessary that on the first one only you have to do, but successive days, 3rd day, 4th day, we can do it. And also I have a question to Dr. Preeti. If there is rebleed, then how do you manage it? And ideally, hyphema drainage, like paracentesis, when it should be advised. Like that message should not go to audience, that even if there is grade 2 hyphema, grade 1 hyphema, we can go for paracentesis. Ideally, paracentesis, when it should be advised. And second, if there is rebleed, then what one should do. There's 8-ball hyphema, I washed it, second day, there is a rebleed on 4th day, then what should I do? 2 questions.
So the first question is, as I said earlier, that grade 2 hyphema, if the IOP is controlled, there's no corneal staining. You don't really need to do, and I'm not saying paracentesis, I'm saying AC wash. Only paracentesis and typically I tamponade with air whenever I do AC wash. So that is one thing. So AC wash, if medical management does not work, otherwise a trabecular meshwork in case of a small bleed will take care of the hyphema on its own. Second is, but if it's an 8-ball hyphema, typically the pressures go very high, but even then conservative management does work. So if the pressures do not come below 40 after say 3 to 4 days in an 8-ball hyphema and there is corneal staining, then you should take the patient up earlier. Again, there is always a chance that there will be a rebleed. So first is to counsel the patient, because otherwise the patient is going to say, kitni baar karne ka hai? So you have to say that we are trying to remove it because the pressure is high, there is a small thing, but tamponade it. And when you are retracting, if you see retinal surgeons do, when they do air fluid exchange, you remove the fluid and you put in gas. So similarly, instead of gas, we are using air. So you can use that, and the second time if you are taking the patient up, then yes, you should do that. But there have been cases where the rebleed does occur. But first is to counsel, and after the second time if there's a rebleed, I have not had a problem so far. But the possibility is always there.
That's exactly what I was going to tell you, Preeti, because instead of doing, even if you do a paracentesis, and then you inject an air bubble. Instead of that, it is better to do a simultaneous one, where you position the patient's head, you go in, inject a little air, take it a little out. So it's a replacement
Yeah,
of
the air fluid
aerobic
exchange as
with-
what you all do.
yes,
Yeah.
exactly. So it works better because it doesn't allow that hypotony to set in
Yes,
for a
yeah.
fresh bleed to occur.
So any role of
Tamponade.
aminocaproic acid which is
Sir, I
spoken
have never
about?
used it. It is mentioned in theory,
Yeah.
and there are very few surgeons who use it. But it can, in case of things like this where you have constant
Rebleeds,
rebleeds,
yeah.
you may use it. But I have never used it, sir.
Is it available and is it?
I don't even know about that, sir.
Okay.
Another one
Okay.
indication
So
which
it has
I
been used.
think you should also have added is traumatic endophthalmitis, because you get in penetrating traumas, you get traumatic endophthalmitis, and typically that causes a kind of a exudate all around the angle. So it causes a pressure rise. So even when we do surgeries, we have to go and literally strip off that area, otherwise the angles don't.
Don't.
I think in case of very clotted 8-ball hyphema, using irrigation and vitrectomy is very useful because it will strip out like exudates or clots, and at the end directly we start the air, continuous flow of air that will keep stopping, and that pressure we can control of the air. So it will cause the pressure hemostasis. And I just have a question, what is the role of vitamin C and K? Can you use that for to prevent the recurrent?
We do
You
give
can
it, but
use it.
how
You
much
can-
it works, typically when
no
a patient
evidence to say.
of
You can.
Evidence
hyphema
based.
comes, we give vitamin C.
Yeah.
So, but how much it really works, I don't know, but as a protocol, we do give it.
But there is no harm, I think.
Yeah,
there
there's
is
no
no
harm.
harm. Just I want to
No,
add
vitamin,
one, one point regarding Madam's question recurrent. If you think for recurrent, we can go for C3F8 also. If there is a patient is not prone, and my always I remove and immediately I just wait for a moment. If there is a rebleed on the table, there is a tendency for recurrent bleeding. In such case, you can use a viscoelastics for 1 or 2 moments, high viscoelastic, and then aspirate, and then, but this is not a good one most of the time. But in such case,
I think
C3F8
we'll
is
go on to the next one because Akshay will miss his flight.
yeah.
Thank you. And Akshay, you will not miss your flight. Go ahead.
OTSI will be happy to reimburse a new booking, I hope. All right. So I'm speaking on evolution and management of blunt adnexal trauma, and just give a brief of the guidelines. Now, going into fracture management for the treatment of each type of orbital floor fracture, medial wall, lateral wall, would probably be too extensive and beyond the scope of what we need as an overview, how to diagnose and how to refer the cases of trauma. So what I'm going to do is, I'll be excluding globe trauma because that's going to be spoken later. We'll talk about assessment, evaluation, what are the imaging sequences that we need, and some special circumstances of how to screen and diagnose, and points to keep in mind when you assess a patient with suspected orbital fracture, retrobulbar hematoma, and what to do as the first step of management when you come across a patient with traumatic optic neuropathy. Hopefully we would not have the controversies that we had in glaucoma management here. The first thing is in case with any kind of trauma, and I stress on this because oftentimes patients with severe head injury are the ones who present with adnexal trauma, and in a lot of patients they are not in a coherent conscious condition, so it's important to make sure that just like we would do for tumors, so is the case for trauma. There is life salvage, then there is globe salvage, and then we look for vision salvage. Once the patient, an airway has been secured and the patient is stabilized with vitals being stable, we can then go on for concurrent treatment management for managing everything else. So general status, ocular status, rule out life-threatening emergency, is then we go into the eye. So when we look for trauma, it's important to note the mode of trauma, the direction of the trauma, and the way in which it happened, because that will help you to understand if there are other coexisting penetrating injuries or not. It's important to know the duration since trauma, because in a lot of cases the sequelae of trauma is evolving over time, how severe it is and how extent it is. So when we talk about the orbit, whenever in doubt, imaging is required. X-ray of the skull in any view, whether you call it a Waters view or heads up view, paranasal sinus, is completely obsolete and does not aid in the management, diagnosis or management of any sort of bony trauma of the skull. CT scan is preferred because it helps you understand the bony anatomy and tells you exactly where the fracture is, or even if there is an intraorbital foreign body, if it is metallic, it will be better that visualized in CT scan, and obviously MRI is contraindicated in such a case, so you have to be absolutely sure that you do get a CT scan. When you are advising or requesting a CT scan in cases of trauma, ask for a CT scan of the orbit with 2 mm cuts, coronal and axial slices, and speak to the radiologist if they see a floor fracture, if they could send reconstructed parasagittal cuts as well. If you're suspecting traumatic optic neuropathy, you can even ask for 1.5 mm cuts at the orbital apex. So now you have a patient with a suspected fracture. What do you look for? Obviously, vision and pupils come in first. Ocular motility. It's important to know the motility because if there's an entrapment of a muscle, the action of that muscle would be limited. The action opposite of that muscle. For example, if the inferior rectus is entrapped, elevation is going to be restricted because the inferior rectus is going to be tethered at the fracture site. Palpate the orbital rim to check for a step deformity that tells you that the rim is involved in a fracture. Check for enophthalmos. If there is an entrapment along with prolapse of the orbital fat into the maxillary sinus, the eye does go into enophthalmos, and this is one of the things, like I mentioned, is a progressive condition that evolves over time. Enophthalmos worsens immediately after trauma and continues to worsen over time. Crepitus and emphysema. So crepitus is the palpable crepitus that you feel of air bubbles in the subcutaneous space, and emphysema is the air that enters there. So crepitus or emphysema occurs typically when there is a communication between the airway and the orbit. That will happen most typically in cases of a medial wall fracture where the ethmoidal sinus is breached and the patient sneezes loudly or forcefully. So you need to tell patients in suspected medial wall fractures as well not to sneeze or blow their nose. Trismus. Now when the patient is unable to open their mouth, you should always ask these patients to open their mouth and show how much their mouth opening is, because if there is a ZMZ, zygomatic or maxillocomplex fracture, they will be unable to open their mouth fully, and that will give you an idea that, okay, there is a fracture and we need to refer. Infraorbital hyperesthesia, the division of the infraorbital nerve is a sensory nerve that goes right all the way up to the upper teeth. So the distribution of that nerve, you will feel that the patient will tell you that the sensations are much lesser on that side. All of these have to be documented while evaluating a patient of this. So what is this? Can someone one of the residents, if they know what is this, what is the halo sign? CSF. So that's right. So in a suspected NOE or naso-orbitoethmoidal fracture or fracture of the cribriform plate of the ethmoid, patient may have some sort of bleeding from the nose. You put in a Whatman filter paper or even a plain white muslin cloth, and you will see 2 rings. The first ring is the ring of diffusion of the blood and the heme in the blood. The second, because CSF is much less viscous than blood, it diffuses and spreads out more. So if you see 2 rings compared to just 1 ring of blood, this is indicative of CSF, and that requires an immediate treatment. So getting especially in patients, you also can get this from the ear. Patients with petrous or temporal bone fractures can also have CSF coming from the ear. So rhinorrhea and otorrhea, whatever is the content, should be checked for presence of CSF. Now broadly, without going into the details, orbital fractures can be classified as simple and complex. Simples are ones that involve only one bone or one wall. Complex typically involve the rim as well as multiple bones. A blowout fracture is the most commonest, and it presents first to the ophthalmologist because the posteromedial wall is the thinnest wall of all the orbit walls. You can see upgaze will be restricted. So now you've done a CT scan, you've identified that there is a fracture, you're unsure if there is an entrapment or not. So there are some clear guidelines on what are actual indications for repair in a case of blowout fracture. If there is clear entrapment with motility restriction, in children if there is a triggered oculocardiac reflex, If patient has diplopia, not just in primary and down gaze, but in all gazes, gross enophthalmos and late enophthalmos are relative indications for surgery. So in complex fractures where you think there is a zygomatico maxillary complex fracture, it's actually not a tripod, it's now called a tetrapod fracture. This is what you can request the radiologist for, which is a 3D reconstructed scan. So that can give you an exact topography of where the fracture is. So from the fracture, we'll come to the soft tissue. Retrobulbar hematoma can also occur in cases of blunt trauma. And in these cases, it is basically an acute orbital compartment syndrome. The blood gets accumulated there. There is no space to go, and it progressively goes on increasing. Pain, RAPD, proptosis, ophthalmoplegia, and reducing vision, or IOP more than 40 mmHg that presents to you in an emergent condition. A lateral canthotomy and cantholysis are extremely urgently to be performed. Subperiosteal hematoma can present like this. The scan below, the parasagittal scan, is the classical appearance of a subperiosteal hematoma. You can see the fluid collection in the subperiosteal space. Indications for intervention, which would mean a needle, pushing in a needle through that space and aspirating, would be diplopia that persists, motility restriction, reduced vision, or gross choroidal folds. So in these cases, you want to aspirate. I'll quickly cover my last topic, which is traumatic optic neuropathy, which can either be because of direct avulsion, direct trauma, or indirect trauma. A quick show of hands. Traumatic optic neuropathy, patients with counting has a blunt trauma. A CT scan done shows no bony impingement on the optic nerve. Vision is counting fingers, 30-year-old male. How many would give steroids or IVMP, IV methylprednisolone steroids at presentation? Show of hands. Okay, how many of you all will not give steroids? So just 3 people, 4 people will not give steroids. All right. So the investigator of the first study that studied the effect of steroids on traumatic optic neuropathy, they used a rat model where they used a rat to create artificial, simulate the crush trauma, was Dr. Kenneth Steen-Sapir. And in this very telling commentary he wrote couple of years ago in the IGO for a review on traumatic optic neuropathy, he concludes, so this is the author who first recommended megadose steroids. He says, the study and all the data that they have, so he's the one who wrote the IONTS, the International Optic Nerve Study, said that it does not imply in any way that corticosteroids are useful for treating traumatic optic neuropathy unless there is new experimental data that defines a role for high-dose steroids. Their use in the treatment of traumatic optic neuropathy should be abandoned. I don't think there's any more conclusive evidence. There is unfortunately no class 1 evidence to show traumatic neuropathy improves with steroids. So I think more than the patient, it is for the operating surgeon or the treating physician that we are giving steroids. Just one note is traumatic ptosis. If you have a case of blunt trauma, observation is the best thing to do. Time is your best friend in these cases. So to summarize, systemic, we always go triage systemically, periocular and then periocular. In cases of orbital trauma, image immediately, which is CT scan, your choice of imaging. Traumatic ptosis is something you can wait and watch for 6 months, because in these cases, time really is your best friend. I'd like to thank you for your time.
Thank you. That was a very good carry-home message for all of us, and especially for general ophthalmologists with regard to what they should look for in case of a blunt trauma in the region of the globe and around. So,
sir, I have one question to exchange. You after the
repeat the
conference,
question.
I'll tell you.
Repeat the question.
Whose skull was it that got punched on top? So I said, I'll tell him after the conference. No, they're just showing how blunt trauma most commonly occurs is actually a punch, which accounts for more than half of all blunt traumas in the eye.
Especially if there are strong men doing it.
Sir?
Especially if strong men
Strong.
do it. Okay, Jayant.
Actually, you are mentioning that is in a rabbit, it was a crush. it may be a direct crash, so there may not be edema. I want to just say point, but in our orbital trauma, there is a lots of diffuse edema all around, surrounding. It may not be that role of advocacy for steroid is there is no such harm until unless there is an intracranial injury.
Right.
Of course, there is an intracranial injury. We should not start any IV methylprednisolone. But once the physician is concerned, as there is so many points regarding moment if you observe the CT scan or MRI, there is a surrounding inflammation, not only the optic nerve. So that steroid probably may help on such patient where there is a edema which may hamper the vascular supply further.
Sure.
So in such scenario, we can assess and
Right,
accordingly.
sir. I agree with you even, and my hand was also up when I said steroids in
Thank you,
traumatic
thank you,
optic
So I
neuropathy.
think, and the reason is that if you don't, he'll go to another person.
Correct.
He'll
And
be
they will.
dissatisfied with you. He'll give him IV steroid, and he will blame you for
Yeah,
not.
and not
having
only
it.
that, whatever vision which would have come across
So since
because
there's
of
no evidence to say that it is pakka evidence at this moment to say that nahi dena chahiye, so I think most people would give it.
and even and in traumatic optic neuropathy, almost a third of patients have some spontaneous recovery of vision, which then they will attribute to the steroids anyways. So.
So I think just 3 carry-home messages mainly. Have a high index of suspicion for 1, orbital fractures, 2, possible canalicular injuries as well,
Yeah.
and 3rd, even a trauma involving eyelids with even a marginal cut or a laceration or a laceration which needs repair. So look for all of them
And actually, just one more point. If we do a CT scan in traumatic optic neuropathy and we don't find a bony fragment impinging, but still doesn't account for the vision loss, we can do an MRI with contrast, because in those cases you may actually see an intra-sheath hematoma, which then would be an indication for urgent decompression.
So I think the fact remains that surgical intervention is needed in a minuscule number of cases
Absolutely.
of optic
Trauma.
optic neuropathy.
Right.
And the definitive indications are only a definite compression shown, either bony or a hematoma, or a progression which was actually documented, that the vision is dropping from say 636 to 260 or something. So those are the 2 definitive indications. Otherwise, as of today, there are no indications, and they're all indications for you to run away for your flight.
Yes.
And we can add that there should not be nose blowing whenever
Yes.
it's a thing, so that for general ophthalmologists we should say
Absolutely.
that. And the thing when you say that movements we can check, we can order for dynamic MRI, because most of the time you will not get oculocardiac reflex. There can be simple flap tear.
Sure.
A flap tear of muscle will not give you the clue.
True.
So for that we have developed the algorithm for this
Dynamic
flap tear,
MRI.
and that can work very well.
Great. Thank you so much.
Dr. Prashant,
Thank you.
about first segment manifestation of closed
Yeah.
open TVs.
Yeah, thank you. I would be speaking on retinal detachment in a blunt trauma. Thank you, OTSA, for this wonderful opportunity. Well, we all are aware of the various mechanisms, how it happens, and predominantly these detachments, which are seen in younger patients, almost 11 to 40% of them are secondary to the trauma. And they are more so seen in a high myopes, with a classically having GRT and nasal dialysis. The incidence varies from 3 to 6%, and classically it is seen more so in a young patient because they are more prone for injuries because of their active lifestyle and also sports and all. These are the eyes in which after receiving a trauma are more likely to develop a detachment. And what are the mechanisms? This is for the sake of postgraduate. It can be a coupe or a contra coupe, which is classically illustrated in figure. So that leads to various direction of forces leading to shearing, which can lead to retinal detachments. Classically, the most common type of a break which leads to detachment is a dialysis. In 53% of a traumatic RD, it is the dialysis which is elicited here, which might be associated with base avulsion. And if it is associated with base avulsion, a dialysis, it is pathognomic that this detachment is secondary to retinal detachment, even when the patient denies the history of having received any trauma. Round breaks are unlikely to be the reason for traumatic retinal detachments. But yes, over a period of time, sometimes what happens because of a gliosis and scarring happening in a blunt trauma, over a period of time can also lead to retinal round breaks. Horseshoe tear is another entity type of a break in almost 11% of the patient. Usually, classically, they are seen, as you can see, at the anterior edge of the posterior edge of the lattice or at the edges of it. Most of these detachments do not present acutely, they present later. Blunt trauma, remember, less than 30% of the diagnosis, and more importantly, they present late and they are picked up late. And that is the other reason, this is the reason why you have significant delay in the diagnosis, and this further added to it by young uncooperative patients. Sometimes if they have associated systemic injuries, associated media haze, we fail to pick up the detachment. Traumatic detachment per se is associated with more significant PVR compared to a rheumatogenic retinal detachment, because these patients are younger, they present late, they have associated inflammatory factors in the form of hemorrhage, inflammation, and smoking is a matter of, it has been implicated rather. As happens, you have to go ahead with a classic examination because you have to take vision. Equally important, I should say, I will just run through this slide. Most important thing is, in a case of a blunt trauma, indirect ophthalmoscopy is must with indentation, and you can pick up lesions like choroidal rupture, Berlin's edema. Berlin's edema as such needs no treatment, but remember, this is a retina which is edematous, which can later give away and form small holes there. This is a case of a retinal detachment associated with a displacement of a lens. And importantly, I forgot to highlight repeated examination. So you, in a case, a young patient who receives a trauma, as I said, might not necessarily have a holes or a detachment at the time of injury. Subsequent evaluation, say 4 weeks, 5 weeks later, and periodically following that, you will be surprised to see the development of holes, because the vitreous changes which happens and leading to vitreoretinal adhesions and pull tend to manifest the detachment and the hole formation even in a later stage. I don't think I need to stress the importance of evaluation of uninvolved eye. In a hazy media, B-scan is very important, and more importantly, again I repeat here that the serial B-scan is mandatory, because you have a hemorrhage, initially the detachment might not be there. So you have to do periodic serial B scans to pick up a detachment and all, or new vitreoretinal relationship which can pick up. And how do you differentiate between a PVD and detachment? I will not run through it. Sometimes you will be surprised, even if it is a blunt injury, patient says it's a case of a blunt injury, but you would pick up a foreign body. You can also, B-scan can also give you the integrity of a posterior capsule, and for that, because that will help us in deciding the type of management, whether we need associated management of a lens or not. This is a retinal detachment associated with a lens dislocated cataract. Do we need ancillary tests like CT scan and MRI? Yes. If you are not sure whether it's a blunt injury, is there an open globule, CT scan can give you what is classically called as a flat tire sign, or associated comorbidities in the form of muscle rupture or a foreign body can be picked up. Whenever the index of suspicion is high, you should not hesitate from doing these ancillary tests. So if you have a break at this stage of pickup after a trauma, simple thing is you need to do a PEXI. You can do it with the help of a cryo, or you can do with a laser. Laser leads to less inflammation, and if the media permits it, if the haze is not bad, you can definitely get away by doing a barrage laser around the breaks. But if the media is more hazy, there is a hemorrhage where you cannot reach out through the laser, then comes the role of cryopexy. If you have a detachment, the primary procedure of choice in such cases is scleral buckle. Why? Because these patients are young, they do not have PVD, there is the detachment, buccal surgeries have shown to have a superior success rate, and even if you need a resurgery, the success rate is better. So this is a classic buccal which is being done. I will just, for the want of time, this is classic, and you also put an encircling band along with a tire in the area wherever there are breaks. And this is I think I will just run through it. So this is the closure. Vitrectomy is done for a detachment if the detachment is associated with hemorrhage, vitreous hemorrhage, posterior tear where we cannot reach out with a buckle, or the patient which has associated dislocated cataract or a macular hole or a PVR is more so. And when do we also add an encircling band to a vitreous surgery? When there are larger dialysis, inferior breaks, very severe anterior PVR. In such cases, you might add along with vitrectomy an encircling band or a belt buckle. And this is the goal of vitrectomy. You clear the media, you relieve the traction, reattach retina and use a tamponade. The prognosis as indicated, I will not run through it, I will just move on. So what are the prognostic factors? Whether you can manage with a scleral buckle or an encircling band, that iatrogenic breaks, the need of tamponade and need of lensectomy. So if you need lensectomy or a tamponade, naturally the severity of injury is more and so is the prognosis less. Now this is a patient who had a detachment, high myope patient who had a 270-degree giant retinal tear. So here we begin, you can see the anterior flap of the giant retinal tear blocking the infusion port. So that is what I am trimming. And after I do vitrectomy, in most of these cases, the posterior vitreous detachment is complete. So I have unfolded it with the help of a perfluorocarbon. Now I am shaving off the anterior vitreous and the anterior flap I am eating off with the vitreous cutter, because if you leave a redundant anterior flap, it leads to more PVR and sometimes it causes neovascularization. You can see the ciliary processes over here. Okay. So this is we are doing with the help of a 3D surgery. And now I remove the PFCL bubble. I decide to do an ILM peel for the macula. Macular peel I do. And following that, once I complete that, the laser, again I put the PFCL, do a laser, and a tamponade is put. This traumatic retinal detachment is associated also with a large macular hole. So in these cases, if a significant PVR is also there. So in a classic case of a macular hole, what you do is you complete vitrectomy, you peel the internal limiting membrane or stuff it into the macular hole. Here the challenge is the hole is not necessarily only because of a tangential traction. There is a significant PVR in the periphery which is leading to contraction of the retina. So in such cases, tackling the peripheral PVR is equally important, and that can be in the form of just membrane peels, or sometimes you also do it as you can see, I have done a retinectomy for this patient. So this is another case of traumatic retinal detachment with old GRT. Now, as I said, sometimes it is also associated with comorbidities in the form of a subluxated cataract, which also need concomitant management, as you can see. So after doing vitrectomy, I am doing lensectomy. The challenge of doing lensectomy in such cases is that the retina is very mobile, and it tends to come into your active ports of fragmatome. And you have to be very careful. You have to get the lens into the mid-vitreous cavity or almost into antivitreous and stay away so that you don't create iatrogenic breaks. Now this is another comorbidity. You can see you have a lens detachment along with a IOL. So this adds further to the complexity of such surgery. So you have to remove the IOL as well after doing a vitrectomy, and then suture the corneal wound through which the lens comes out. And after that you have to do the surgery. As you can see, I have removed the lens and the rest part is almost similar. While this is an open phaco wound because of a blunt trauma. So remember, whenever you have a blunt trauma, especially in an operated eye, the first place whether it is a closed globe or an open globe, if you want to ascertain, look at the wound site wherever the phaco or a cataract surgery is done, and most of the time your diagnosis would change from a closed globe injury to an open globe. So to summarize, 11 to 40% of rhegmatogenous retinal detachments which we see in our practice are secondary to trauma. Classically they happen in a young patients where they manifest late, they have a delayed diagnosis, they have more severe PVR, and that's the reason why many a times the prognosis is lesser. Dialysis and giant retinal tears are the type of breaks which are more commoner in a traumatic retinal detachment. Whenever you screen for a blunt trauma, remember indirect ophthalmoscopy is the only way to look at it. Sclera and buckle still is the procedure of choice, primary procedure of choice, unless associated comorbidity in the form of PVR, macular hole, dislocation of lens. And you importantly need to also tackle associated comorbidities, and in such cases you do a vitreous surgery. Thank you.
Thank you, Prashant, for that excellent summarization and excellent presentation, very well illustrated with videos.
Sir, I will make one announcement with your
Yeah.
permission.
Yeah.
ARC has decided to go ahead with OTSI and launch a CME series on ocular trauma, which would be like a coffee book table. And with your permission, I have decided Dr. Mrs. Shah to be the lead author, and we are inviting the younger people to contribute to the chapters.
Great.
And the senior people will be the mentoring those authors, and they will be and we will create a coffee book table which will be on everyone's table for their clinical practice.
Thank you.
Thank
That's a great measure.
Prashant, I
Now
have
first, one question, Prashant, before
Yeah.
I hand over to the two of you. What are the three commonest causes of decreased vision after blunt trauma attributable to posterior segment? And then I hand over to the two of you.
Okay. So the commonest reason, I don't know the statistics point of view, but one is the traumatic macular edema. Second is sometimes
Sequelae of
blunt traumas. Yeah, one is that one you can expect is a choroidal tear, and third is of course a detachment which later on manifests, or a traumatic submacular hemorrhage, or whatever we can call. Madam, can you add something? I don't know the sequence statistics point of view, incidence wise.
vitreous hemorrhage.
Yeah.
let's say persistent poor vision or persistent decreased vision, say 1 month or 2 months post-operative.
Yeah, then it's a traumatic macular edema leading to an atrophy or an hole or an epiretinal membrane formation, sometimes a choroidal tear.
Macular hole.
Yeah, macular hole, yeah, that all becomes into the same.
In a situation where you find, you take the patient in, and on exploration, you may find the scleral rupture.
Yeah, it's not
Then
uncommon.
it's very common. But what do you plan? You suture the rupture and defer the retinal surgery, or you continue with this during the same CT?
No, it depends upon, see, concomitant means you are talking about primary surgery versus a planned surgery for a vitreous. There are multiple things which come into the play. The primary thing is if it is an open globe injury and associated with retinal comorbidity, and we are planning to do 2 procedures, whether it can be at a single step or a 2-step, that is what the question is, correct? So if the wound is away from the visual axis and I can achieve a good, a proper closure of the wound which will prevent leakage during the surgery, I would like to do it, especially in cases where I fear infection or the type of a foreign bodies which can lead to more inflammation. But if not, I would like to primarily close and then take at a second step, say about 7 to 10 days later. But the message which should go across is that whenever you do a wound repair, please do not refer it to the vitreoretinal surgeon, say about 3 weeks, 4 weeks, 5 weeks later. They have to be referred within 7 to 10 days, because that is an ideal window when you get the best of the success when we as a vitreoretinal surgeons go inside and do surgery.
So by that time, the EVD has also taken.
EVD has happened, and otherwise what happens if the patients are referred after 2 to 3 weeks, the PVR is so severe that many a times we have to abandon the case. We may not be necessarily able to open the funnel.
That criteria, I think, is changed. 100 hours second surgery.
Correct.
About
Karobi.
14 days would be the ideal time
Maximum.
to go in for the second time.
Yeah.
And mostly it is a 2-step thing, but if you see that thing of hemorrhage over the conjunctiva transgressing into the orbit, you know that there is a scleral rupture, so always at the first thing you have to open it back and suture it. There was one thing which I wanted to highlight, is that one indication which you should have touched is that of a shaken baby syndrome.
Okay.
Because this is one aspect of a blunt trauma where there is no history of injury. Nobody knows how it has happened, but the child suddenly becomes comatose. 80% develop a lot of hemorrhages, but in a lot of patients you do get changes in the retina where retinal detachment, etc. also occurs along with it. So that is something which requires mention.
Yeah.
Because that's,
How commonly do we see it?
in my practice of 33 years, I've seen 7 patients. And they have to be
what
picked
is
up
your-
because there's never any
I did
history.
not see any patient.
What
There's
about
never any
Prashant?
history because you have to dig for the history.
Prashant, any cases seen?
Seriously, I know her, she's very passionate about the pediatric cases and she picks up. But probably I might have missed in a busy OPD. Very truly said by Dr. Kairobi that probably we really don't look into it, or probably we are not oriented to look for it, I believe.
Yeah.
I accept that.
Actually, the thing is that this is a problem where, like, the police forces and all have to be sort of
Alerted.
yes, but in our country, sadly to say, that even if it is a frank case, no action is taken. Absolutely no action. They just cover it with dust, so it's really bad. Prashant, do you use general anesthesia for examining any of your patients of the pediatric age group, or do you do it without? The peripheral examination which you have to do maybe
Yeah.
3 weeks later, 4 weeks later.
Frankly speaking, it's a very subjective decision. You try to do an indirect ophthalmoscopy if the patient is not allowing you. You try, I know it might sound a bit harsh. We used 2 Desmas retractor and tried to see at least up to the equator and beyond. If we see that it is comfortable enough and we can avoid anesthesia at that point of time, I might even not worry about it. But because you need to get tide over the initial phase of, after trauma, that patients also cool down. But yes, if it is associated with a significant vitreous hemorrhage and I am feeling something is fishy, that is the time probably I might subject him to general anesthesia just for diagnosis.
We do the EUA.
Okay. Thank you.
Thank you.
At the outset, looking at the people in the whole, we request all of you to be a part of Ocular Trauma Society of India and be a member for Trauma Society, and that will help a lot to learn about all this trauma.
Sure. Thank you.
Okay, then we go on to the next part of it, blunt trauma to the anterior segment. I think that's a big subject and the right person to tackle it. President Brasine, who's also the Senior Vice President of the Ocular Trauma Society of India.
Thank you, sir. Anterior segment injuries. Really, it's a big subject. I will touch some part of it in my way, and this will be a case-based presentation. So, cases can present like this in variety, and they all are really looking bad to begin with, and but ultimately we can give good vision if we do manage these cases in a better way. So my first case is a 35 years old lady. She had an injury with a green stick, wooden stick in the left eye, followed by pain, redness and decreased vision, and the vision was 2/60. She presented to us late, and by that time she had this kind of a picture. And this is a layer of dematous or pigmented fungal keratitis, which was examined. And the management goes as like a topical and systemic antifungals and antibiotics are given. And we gave intrastromal voriconazole also along when the sheet was present. And then we did a therapeutic scraping, and in a scraping, like we did later on, we did a superficial keratectomy, and this is the AIOCT before, when this plaque was there, plaque-like thing was there, and this is the OCT picture, and this is how this whole thing came like a plaque, which from chapati jaise hoti hai, it came out of it, and we did. In between, we had to dissect it with the knife and with the blade, and this is how we did a superficial keratectomy. And after this, the penetration of the drug started in a better way, and the patient healed with some haze. And this is the post-operative AIOCT. There is a thinning in the region of the keratitis or the fungal keratitis region. Another case, 35 years old male, had a penetrating trauma. Corneal tear repair was done at some other place, and the patient came to us with the presence of pseudoterygium at 6 o'clock with a 16 diopter cylindrical power, and with cataract formation, and there was an iris defect present. And 6 months after the primary repair, we planned, this is how the IEL master reading was. So 6 months later, we planned for the cataract surgery with the 11 diopters correcting IUL. And this is how the patient looked when we did the cataract surgery. So we released all the anterior posterior synechias and performed the capsular access, gentle hydrodissection. Case was soft cataract. But here you see, while I was aspirating the cortex, we find that there is a vitreous present in the region where the. So immediately we came out and filled the chamber with viscoelastic. We used aniridia rings, and these rings, they decrease the size of the pupil as well as they worked as a of the capsular bag. And with this 11 diopters correcting IOL was placed. This is from Rayner company, and patient got rehabilitated with some residual astigmatism. Later on, after 6 months, we released the pseudopterygium and we found that the sutures were present there, and we released those sutures also, and then the patient improved to 6/9 vision with minus 1.5 diopters of cylindrical power and 0.5 diopter of sphere. So another case, this is a firearm blast case, injury case. This child, 17 years old male, was enjoying the marriage function, and during the marriage function, you see atishbaji hoti hai. This fire, this thing is there. And at the same time, some local firearms are also there. So this is something which happened to this young child of 17 years old. He came to us with bilateral PLPR vision. Intraocular pressure was 18 in the right eye and 40 in the left eye. And the picture was that multiple embedded foreign body over the skin and over the forehead and in the cornea and sclera. So right eye there was a sealed corneal tear, and in both eyes there was a traumatic mature cataract with ruptured anterior capsule, and on B scan we could find there were vitreous intraocular foreign body in both eyes. So this was the picture. So this is how we went. We took left eye first because that the pressure in this eye was normal, and we managed medically in the other eye. So you can see there is a floating intraocular foreign body, which I thought I will be able to catch it, but it suddenly went behind. And then with the help of vitrector, there is a primary PC rent. We did this case, and after a week, my retina surgeon, he removed this intraocular foreign body, and the patient was kept aphakic. Now with this experience, this is the right eye of the same patient. So primary sealed corneal tear were reinforced by the sutures, and we have placed a infusion at the pars plana to float this foreign body because it was there in the other eye. So, and that similar kind of foreign body was there. So with the help of paracentesis, this iris is coming out because there is a pressure from behind because of the infusion cannula. So we sutured it, and then with the vitrector only. Mind it, we can do it with IA, but vitrector gives us the facility that we can cut the vitreous along with and remove the cortex also simultaneously. So this eye, after the 2 months later, we released the synechias, adhesions, and this was the left eye, and we did a secondary implantation. This was the better eye, and the optic capture was done in the capsular axis, and in the right eye, which was where the multiple tears were there. So we did rehabilitated this patient with the help of secondary IOL implantation because there was not adequate capsular support. So we did a Yamane technique and rehabilitated. It's your choice, whichever way you want You can go for a retro-iris fixation or the glued IUL or anything. That is your choice. And we rehabilitated this patient. And in this eye, there is a residual refractive error post this thing surgery. But in right eye, the patient is having 6/9 vision. In the left eye, which best corrected vision is 6/12. So coming to the cases of intraocular foreign bodies. So they come to us when you see there is a sealed corneal tear, and with the corneal tear you see some hair-like things are there, and these are eyelashes. There are two eyelashes. They have to be removed because they will create a reaction inside the eye, and one more eyelash is there after this, and then the surgery is performed, and like now this child, 7 years old male, came to us with the injury by the pencil. His friend, nowadays there is a lot of arrogance, even in the children there is arrogance. So his friend in the classroom, he poked pencil into his eye. So this is how the patient came to us from some 600 kilometers away, and there was a large foreign body embedded in the lens, and this is the lead of the pencil, such a big foreign body. And it was so difficult to release all these adhesions because the lead induces lot of inflammation. And we just cut it, all these, the fibrosed, the lens matter and the fibrosed posterior anterior capsule and the adhesions of the iris with the lens matter and the cornea, and released everything, and removed all the cortical matter and placed a PMMA lens, because my opening was already large for removal of the, so, and I was not sure of my capsule support, so I placed the lens, PMMA lens, in the sulcus. And this patient had severe inflammation in the post-operative period, severe fibrinous reaction in the eye, and which persisted for almost 2 to 4 weeks. And but fortunately, it was not endophthalmitis. Fortunately, it was not. It was restricted to the anterior segment only. It didn't. It was not in the posterior segment. So we were very sure of that it is going to be relieved, and we were the patients were also reassured that way. Another case where we can see, you can see there is a stone piece there present in the anterior chamber, and with a large tear. So we removed this after the tear repair, and usually there is a tendency to remove these foreign bodies or fill the chamber through the main tear only. But I tell you, it should not be done. It should be done separately through the limbal port. Like we remove the intraocular foreign bodies, the retina colleagues, they remove the intraocular foreign bodies. So this is again, but we could rehabilitate this patient. Patient had a fairly good vision after this the repair and surgery also. So this was almost 6 millimeter size foreign body with a 3.5 millimeter. So any corneal, my say for the traumatic cataract management is that if there is a simultaneous concurrent tear in the periphery away from the visual axis, you repair it, and repair should be offered by a no-touch technique. I don't hold the lip of the corneal wound with the forceps, try to avoid it, and we should use a Rouse-Hayes technique where the peripheral, the sutures are wider and the central one are smaller or less wide. So this will make the cornea, preserve the corneal asphericity and not induce too much of astigmatism. After this, you can perform the cataract surgery, and if you are good enough in surgery, I will request you, in patients younger than 6 years or 7 years old, perform the posterior capsular access as we do it in our routine pediatric cataract cases. And if they if even if there is adequate capsular support, the lens is now buttonholed in the capsular axis, and then this eye will remain quiet, lens will remain stable and well centered, and the lens haptics and the tilting of the IOL will not be there. It is not going to touch the cornea or the iris, and UGH syndrome and all those complications are avoided. Cases with
Dr.
corneal
Purendra,
tear,
please.
just last case, um, um, one last case. This is very interesting, if you permit, sir.
Yeah, please.
So, 26-year-old male came to with us with a road traffic accident. There was a large tri-radiate Mercedes-Benz like sign like tear, and it was repaired first. Then we took it and we did a aniridia lens with glaucoma valve, because there was a glaucoma, persistent glaucoma for 11 months. This is post surgery of MF glaucoma valve and a aniridia lens, and the patient vision was 618 part. After 2 years, patient developed a decompensation. We did a keratoplasty and trimmed the tip of the AGV, and post-op patient's best corrected vision at this time is 6/9. 6 years post primary surgery, patient is now happy. He's using one iotim and timolol maleate and lubricant, that's it. So, to conclude, uh, every case should be independently assessed. A corneal or corneoscleral tear repair should be done first. Remove loose lens matter, foreign body, hemorrhage, exudates in the anterior chamber along with the corneoscleral tear repair. In case of suspicion of infection, irrigate anterior chamber with antibiotic. Give intravitreal antibiotic if you suspect the endophthalmitis in such cases. Manage iritis, glaucoma, infection, corneal surface, astigmatism before taking a patient for cataract and IOL surgery. And secondary IOL implantation is a good alternative. And we should always have a plan before going further with this complex surgery. Any intervention should be dictated by what is best for the eye, not by what is possible by you or you are able to do it. Be ready for any intraoperative surprises and anticipate problems that may occur, and we should always have a plan B ready to execute when we are managing these cases, as our ultimate goal is that it's not a good death but a good life to the very end. Thank you.
Thank you, Dr. Purinder, for such a wonderful topic covered from all aspects. And we have a short of time. And I would say, as Dr. Purinder has already mentioned, we should be prepared for all everything in the OT when you tackle these trauma patients for cataract like CTRs, rings, and dilators, or any other instrument, micro instruments for vitrectomy. So we would be well prepared when you take up these patients. Another important message is given for the second implantation of the IOL, which is another issue which is going to give us good results. And though the small trivial injury where we have a very fine small cut in the cornea and we have a cataract too, we can take care call, but preferred is always a secondary implantation. So any question from the audience, you're welcome.
Thank you. We'll have one photograph.
Thank you. Can I request all the speakers to come forward for the photograph, please?